Welcome, welcome, welcome. Day 6, the final leg of the journey. We are here today because we are celebrating World Mental Health Day and surrounding it with World Mental Health Week. Yesterday was World Mental Health Day, and if you missed that presentation, you can check out the YouTube page for that presentation. But today is a wonderful closing exercise, and we have wonderful persons who will be speaking with us today. World Mental Health Day theme was mental health for all. Greater investment, greater access, everyone, everywhere. And we have collaborated with the Pan American Health Organization, the Ministry of Health and Wellness, Western Regional Health Authority, and the Department of Psychology, Sociology, and Social Work at the University of the West Indies, Western Jamaica campus. And we have taken as our theme, investing in mental health, the time for action is now. It's never too late to do something. Today, guiding us on the final leg of the journey is Ms. Georgia Rose, a senior clinical psychologist in the Department of Psychiatry and also coordinator of undergraduate studies right here at the University of the West Indies, Western Jamaica campus. So we are in for a great treat to sit back as we invite Ms. Georgia Rose to lead us in today's proceedings.
Good morning, ladies and gentlemen. Thank you so very much for that introduction, Dr. Crossman. Please permit me to conduct the introductions of our esteemed presenter. This morning, our presenter is none other than Professor Benedetto Saraceno. An illustrious and expansive career, this introduction will by no means capture the expanse of Professor Saraceno's collaboration and contribution to world mental health. He's an Italian psychiatrist and an advocate of mental health reforms. He has been director of the Department of Mental Health and Substance Abuse of the World Health Organization and is the Secretary General of the Lisbon Institute for Global Mental Health. He was trained as a psychiatrist in Italy and was an active militant of the movement Psychiatria Democratica, and I'm sure he will correct my pronunciations when he joins us. The Italian professional group that supported the process of deinstitutionalization and the establishment of a national network of community mental health services. In 1981, Professor Saraceno became the director of a public residential facility for persons living with severe mental health disabilities residing in Milan. In 1996, Professor Saraceno was recruited by the World Health Organization in Geneva, where he became responsible for the program Nations for Mental Health, an initiative aimed at promoting the mental health of undeserved populations. In 2000, he was appointed director of the World Health Organization, Department of Mental Health, later renamed the Department of Mental Health and Substance Abuse. In 2001, Professor Saraceno led the preparation of the World Health Organization World Health Report, Mental Health, New Understanding, New Hope, and of the World Health Day devoted to mental health with the slogan, Stop Exclusion, Dare to Care. He led the World Health Organization Department of Mental Health and Substance Abuse until 2010, contributing to important initiatives of reform of mental health systems in many countries and working towards the promotion of the human rights of the people with mental disability. He played a leading role in the process of approval of the global strategy on harmful use of alcohol by all World Health Organization member states. From 2007 to 2008, he was also the director of an interim of the Department of Chronic Diseases and Health Promotion of the World Health Organization located in Geneva. In 2002, he was appointed Professor of Global Health at the School of Medical Sciences of the Nova University of Lisbon and has been one of the directors of its International Master on Mental Health Policy and Services. Professor Saraceno has been the head of the steering committee of the Gulbenkian Global Mental Health Platform, the chairman of the Global Initiative on Psychiatry, and now is the Secretary General of the Lisbon Institute of Global Mental Health. He is the scientific director of the Center on Urban Suffering attached to the Casa della Carita in Milano, Italy. In 2010, he was appointed professor at the Department of Mental Health of the University of Geneva. I'm sure you now understand the esteem that we have been so blessed with this morning. He is no stranger to Jamaica. He has visited our shores before, and we want to just extend a hearty welcome to Professor Saraceno as he leads us today in his presentation, Investing in Mental Health. The time for action is now. Welcome, Professor Saraceno.
Hello, everybody, and good morning, and thank you for the nice and generous words and a perfect Italian pronunciation. Thank you very much. Thank you. I would like to thank the Western Regional Mental Health Services and the Department of Psychology, Sociology, and Social Work of the University of West Indies and the Western Campus for inviting me to be one of the speakers of the series of lectures in occasion of the Mental Health Week 2020, and a special warm thank to Dr. Elizabeth Crossman. The main topic of this year's World Mental Health is about investing in mental health. Indeed, if we want more investment in mental health, we should be able to provide solid arguments for that. However, I'm afraid that in spite of our ability of raising awareness and providing good arguments for investing in mental health, still mental health is not considered as a priority in a public health agenda. My lecture today will touch upon these two topics. Number one, why mental health should be higher in global health agenda. And number two, why it is not. There are three arguments that we may use to prove that mental health should be put higher in global health and in global development agendas. The first argument is epidemiological, the second is public health, and the third argument is essentially a moral argument. Let's move to the epidemiological argument. We have enough epidemiological data to build the argument showing the relevance of mental and substance abuse disorders, even if compared with other infectious and non-infectious disease. You see the burden, the numbers of people affected. Millions of people with depression, schizophrenia, dementia, you may see in the slides. These impressive numbers represent for sure a convincing argument, but at the same time, they are not enough accurate because they have been generated using prevalence data coming from a limited number of countries, essentially high-income countries, rich countries. And we are not sure they reflect these numbers. They reflect the real situation of the rest of the world. However, they may be useful to give at least the first general sense of the relevance of the problem. But let's be a little bit more accurate. You see this figure showing the global burden of disease due to mental and substance use disorders in the past 25 years. In blue, you see the line representing the low-income countries, so the global burden attributable to mental disorders and substance abuse disorders, but just related in blue to low-income countries, while in gray dark, low middle-income countries. In green, you see the global data, in violet, the high middle-income countries, and in red, the high-income countries. So you see that there are differences among high, medium, and low-income countries in terms of the global burden. However, the burden of mental and substance use disorders increased by nearly 50% in the past 25 years. These disorders now account for 1 in every 10 years of lost health globally. The burden argument, more than using as an argument the mortality data, is much better and more convincing using the disability data, meaning the contribution to disability represented by mental disorders. We have 5 major contributors: unipolar depression, alcohol, schizophrenia, bipolar disorders, and dementias. They represent almost the 32% of all years lived with disability in the world. Whatever kind of disability, 31.7% is attributable to mental disorder. And if you see the leading cause of disability, the leading cause of years of life lived with disability, you see that in ranking in position 1, you have unipolar depressive disorder. In position 4, you have alcohol use disorder. In position 6, you have schizophrenia. And in position 8, you have bipolar affective disorders. So out of the top 10, like when you're ranking songs, the top 10 causes of disability, both sex, all ages, 4 are mental health disorders. You notice that dementia, that was mentioned in the prior slides as one of the major contributor, here is not represented among the top 10. And this is due to simply to demographic reasons, because this is a global figure, and the global figure include countries where the life expectancy is so low and they don't reach the age of the onset of dementia. So when you put high income countries, dementia is there among the top disability causes. But if you put all together high and low income countries, dementia disappear, because low income countries, they have not enough high expectancy life years. You see that if we look at the prevalence of comorbid major depression, for instance, in medical illness, we see that it accounts up to 29% in association with hypertension, up to 22% with myocardial infarction, up to 30% with epilepsy, stroke, diabetes, cancer, HIV/AIDS, and tuberculosis. While in general population is only, relatively speaking, is only 10%. So that shows that there is comorbidity. So there are many physical diseases that are comorbid with mental problems. So I can continue hours to bore you for slides and figures and epidata showing essentially that we have enough epidemiological evidence that the burden represented by mental and substance abuse disorders is quite high, and is very high compared with other infectious and non-infectious disease. But let's now move to the second argument, which is not based on figure, but is based on public health arguments. What I mean that very often, even if the figures are not terribly high, an event or a disease or a condition may represent a real, very serious public health concern. The typical example is mental retardation in children. The problem is not the big number. The problem is the big problem for a community or for a country to still have mental retardation due, for instance, to lack or iodine salt in water. That is an unacceptable public health failure. Refugees, displaced, people exposed to complex emergencies suffer from a broad range of mental disorders. Rates of mental disorders tend to double after emergencies. At least 79 million people around the world have been forced to flee their homes. Among them are nearly 26 million refugees, around half of whom are under the age of 18. There are also millions of stateless people who have been denied a nationality and lack access to basic rights such as education, healthcare, employment, and freedom of movement. At a time when 1% of the world population have fled their homes as a result of conflict or persecution, that shows how the work of mental health in the field of complex emergency, refugee, displaced, war, and conflict is a tremendous public health concern. A second public health concern is the people exposed to major economic transition are at risk for what? For demoralization, for suicide, for alcohol use or harmful use of alcohol, for substance abuse. That's very important in this moment. In the moment of this pandemic, one of the effects of the pandemic, beyond the medical or the health effect of pandemic, are the economic effect. So the major economic transitions are coming to hit all our countries in the next futures. On average, about 800,000 people commit suicide every year. And according to WHO, suicide is among the 3 leading causes of death among 15-45-year-old men and women. And the numbers of suicide has increased by 60% over a 45-year period. Among the young, suicide is a leading cause of death. For instance, is the first leading cause of death for young women in China, and the second leading cause of death for young men in Europe. Suicide as a leading cause of death for young people is supported further for our Lancet Commission on Mental Health. You see, in the European region, both sexes, number 1 cause of death in young people is car accident, followed by suicide, followed by all cancers. And if you look at China, suicide ranked first, followed by car accident and all cancers. Again, mental disorders can also contribute to unintentional and intentional injury, like traffic accident due to alcohol intoxication or domestic violence. If you look at these data, I will guide you in reading this table. Just focus on the 2 red figures, 8.5 and 8.0, related to alcohol. Worldwide, 3 million deaths every year result from harmful use of alcohol. This represents 5.3% of all deaths in the world. The harmful use of alcohol is a causal factor in more than 200 diseases and injury conditions. And if you look at this data in low mortality developing countries, what does it mean, low mortality developing countries? A developing countries which enough health system granting low mortality for children. In low mortality developing countries, men are using alcohol in a way that 8.5% of the mortality is attributable to alcohol. And in developed countries, similar figure, 8%. In poor countries, which means in high mortality developing countries, very underserved countries, very poor countries, very low income countries, alcohol is too expensive. And so paradoxically, the alcohol consumption, the tobacco consumption, the illicit drugs consumption is lower than compared with low mortality developing countries. And last but not least, children. Children not receiving enough ionized salt develop intellectual disability. Intellectual disability affects about 1% of the population. And of those, about 85% have mild intellectual disability. And men are more likely than females to be diagnosed with intellectual disability. You see, these are arguments not just based on epidemiological data, but based on their impact on the public health of the general population and on the public health strategy of a given country. The third argument I will use to support to defend the idea and to convince politicians and policymakers and donors that mental health should be put higher in global health and in global development agenda is the moral argument, what I call the moral argument. Human rights violations of people with any mental condition occur in all countries, in high and in low income, and in all settings, in hospitals, in psychiatric facilities, in residential facilities, in prisons, in institutions for intellectual disability, and last but not least, in the family as well. Now, these terrible pictures come from a large collection showing images from the Americas, from Africa, from Arab countries, from Europe, from Southeast Asia, and from Western Pacific. I can show you a lot of these terrible pictures. The problem is not to create emotional scandal in the people, but frankly, is a little bit to create a more an attitude more open to change and more open to accept the important international covenants and international regulations about the human rights of people suffering from mental disorders. These pictures, I've decided to show you just these pictures, which comes from a European country, from a country which is member of the European Union. So you see that human rights violation is not something that occur only in the poverty settings, or in the poverty environment, but may happen everywhere because human rights violation is ubiquitous. And the important United Nations Convention adopted by United Nations in 2006, the famous UN Convention on the Rights of Persons with Disability, which puts together physical and mental disability represent a gigantic step forward in taking seriously the right of people with disabilities. First, why is so important? Because for the first time, people with mental disability are not discriminated, but are considered together with people with physical disabilities. Secondly, because the convention clearly states that disability cannot be used as a reason for diminishing freedom of people with disability. And third, because the convention force mental health professionals to move, to shift from the etiquette of human rights to the ethics of human rights. Sorry to play with words, but if you so wish, etiquette is a very small, a too small ethics. And psychiatrists too often use more etiquette than ethics. They talk and talk and talk about human rights of people with mental disorders. They talk in their Congress, they talk in their international conferences, but they do not act changing. This means that instead of talking the language of the politically correct, the defense of the rights of people with mental disability should be really implemented. Fourth reason why it's so important, that convention, is because the users' movement slogan, "Nothing about us without us," finds finally a juridical frame that puts life in the slogan. But I'm afraid that is just, so far, is just a juridical frame, but not a real institutional frame, because too often around the world, we still see psychiatric hospitals violating patently human rights. Not just, don't think in torture or just in violence, think simply in misery, in lack of dignity, and in lack of respect of the human life. I hope that with these three arguments, the epidemiological, the public health, and the moral, I have given you the sense that it is possible to convince policymakers, politicians, donors, international funding agencies, the World Health Organization, the PAHO, that mental health should be put higher. So when you have to talk to your minister, I know that your minister is a minister quite exceptionally open and with a very good spirit towards putting mental health as a priority. But there are many countries where, unfortunately, the minister is not good as your minister in this moment. So where the professionals should convince the ministers that mental health is important. You have here enough arguments, a mix of public health, of AP data, and of moral data that can serve your cause and prove the minister that if he is not investing in mental health, he is wrong. But now let's move to the second part of my lecture. And the second part of my lecture is why it is not. So the first part was, why should we put mental health higher in the agenda? But the second part is why it is not, why still it is not. In spite of the 2001 WHO report on mental health, in spite of the several excellent reports produced by academic people like the Harvard report in 1995, the World Report on Mental Health, or like the Surgeon General report of the United States in the year 2000, or like the Lancet series on global mental health, or like the Caracas Declaration that this year is celebrating the 30 years of the Caracas Declaration that in 1990 was for the first time in the region of the Americas, stating the importance of giving more attention and more investment and more resources to mental health. In spite of all this, still the situation is amazingly bad. Let's now look at this figure. Is mental health adequately funded? Investments, both financial and human resources, are consistent with the burden. You see, in blue, 14% is more or less, sometimes someone says it's more 15%, someone says more 13.5%, but let's take 14% as the figure representing the global burden of mental and substance abuse disorders. To treat, to respond, to address the challenge of these 14%, on average, the world spent the 2% of the health budget, devoting this small fraction of the budget to mental health. This is a median, these 2%. Of course, the data are quite different if you look at certain countries where it is less than 2%, and other countries which is much higher than 2%. Just to give you an idea of the certain degree of variety and heterogeneity of these investment in mental health, let's look at this figure. So you have the 4 histograms, starting from left, you have low-income countries, low-middle-income countries, higher middle-income countries, and high-income countries. The red plus the yellow means the global budget for health. So what a country put in the envelope for health. But if you look at the part or the portion of the envelope devoted to mental health, you look at the yellow fraction. So it's like you have a big envelope, and inside the big, this is the health budget, and inside a big envelope, there is a small yellow envelope containing the dollars devoted to mental health. 1.5% of the total health budget in low-income countries, 2.7 in low middle income, 3.4 in higher middle income, and 6.8 in high income. But caution, be careful. These 4 envelopes, they do not contain the same amount of dollars. Sorry, not the small envelope, the total envelope. Because if we consider the countries by income level, there is a considerable difference in terms of the proportion of mental health related to the global budget of health. But the global budget of health is different between low, middle, higher middle, and high income. So in other words, if in the column of high income countries, you put Norway or Sweden, the total budget allocated to health is 100 times bigger than the total budget represented by the total envelope in low-income countries. What is the conclusion? That as much you are poor And as much as your country has a little investment in health, the proportion for mental health is even little and is even smaller than compared with other countries. So in the conclusion is, as much you are poor, as less you invest in mental health. The reasons for that are a number of prejudices that mental health is not a priority, that we have nutrition, that we have infant mortality, that we have SIDA, that we have malaria. All these arguments have been defeated by the number used by the global survey and by many international epidemiological data, showing essentially that not investing in mental health first costs more than investing. So you spend more. Just let's think that in Europe, in my continent here, the first cause of absenteeism in the European Union is depression. So this has a tremendous impact on the economy of the region. So it's probably or surely much better and more convenient to invest in treating depression than leaving depression untreated. In terms of economic rewards, in addition, investing in mental health has an impact on many physical diseases. We know that diabetes and depression are closely associated. We know that obesity and depression. We know that tuberculosis and depression and anxiety and sleep disorders are associated. We know that people suffering from SIDA are much less compliant than people with depression or without depression. Having SIDA and depression equal not being compliant with the antiretroviral treatment. So investing in mental health goes beyond the disease per se. Support family, support the community, increase the productivity of the country. If we compare the percentage of expenditure on mental health care with the years lived with disability, we discover that the expenditure is below any reasonable expectation. Meaning, in blue, in dark blue, here you have the years lived with disability due to mental problems. And in blue, in light blue, you have the percentage of the total health spending on mental health. So you see that the health spending in mental health is rather ridiculous. And if you look at the money spent by international agencies, I mean, United Nations agencies or bilateral agencies, USAID, the British agencies for health, the German agency for health, the Norwegian, the Swedish, the Japanese, the Canadian. If we look at the money spent in general by all international agencies supporting development of countries in the field of health, you look at the HIV/AIDS is in a way representing the biggest part of this expenditure, of this assistance expenditure, followed by maternal and neonatal health, followed by malaria, and followed by tuberculosis. Non-communicable diseases, namely cardiovascular diabetes, cancer, respiratory diseases are not there. And mental and substance use disorders are not there. So in conclusion, the development assistance for mental health is zero, for almost zero for mental health. So all the arguments that I use in the first part of my lectures here are contradicted by the reality. When Bill Gates is investing in health, he's not putting a cent in mental health. The same for many international agencies. So here we have a contradiction. And the contradiction is essentially that on one side, we have the evidence, the impressive evidence that mental health is an important component of public health, is an important component of the health of the community all over the world, poor and rich and medium income countries. But the evidence shows that still the investment is quite minimal, or the mental health is receiving peanuts. Now we have two possibilities here. My suggestion is to use as an explanation of this contradiction, not just the most obvious, which is government they don't understand, we have to educate ministers, we have to educate policymakers, we have to educate politicians about the importance of mental health. They don't know, they don't realize how important it is. In a sense, I put myself among the we, the mental health professional, we have the tendency to put the responsibility 100% on the shoulder of the politicians. They are stupid, they are ignorant, they do not understand, they need to be educated. This is true. This is partially true. But let's also to use another possible interpretation, which is less pleasant than simply saying that the other people are guilty and we are the victims. Let me conclude on a note of self-criticism. Criticism about ourselves as mental health professionals. We have also some responsibility in the poverty of resources invested in mental health. I think that there are some legitimate criticisms that should be directed to ourselves on two issues. First, on our capacity to generate evidence. And second, on our capacity to generate significant change in the real world where we operate. Let me be a little bit clearer. Mental health science provides solid evidence about the magnitude of the problem, provides some evidence, not solid evidence, some evidence about the links between social factors and mental conditions. But the evidence about the cost effectiveness of intervention is rather poor or controversial or weak. In other words, we are much better in showing how terrible is the problem rather than showing how good are we in solving the problems. We produce tons of evidence about the burden of mental disorders, but we produce rather little evidence about the cost effectiveness of our interventions. Why? But because we are not able to provide enough evidence. Our work, the work we publish, there is a lot of process indicators. We talk about the number of visits, the number of staff we have, the number of admissions, the number of discharge from hospitals, the number of visits, the number of medications. We use a lot of that, much more than we use outcome indicators showing the clinical outcome, the functional, the social outcomes. It's very rare that we are showing in a cohort study or in a follow-up studies that 1,000 patients that were observed starting January 1st, 2000, in 2020, they are much better, or they are, or 50% of them are in good condition, 30% are in medium condition, and 20% are in bad condition. We don't show that. The evidence about making a difference in the prevalence of mental disorders is still insufficient. We may say that the incidence of mental disorders do not depend, or does not depend, sorry, on us. We're not responsible if there are a number of schizophrenic people or a number of people with depression being first case in their country in a given time. But we have to prove that the prevalence, so the number of people that in a given day suffering from a disorder are decreasing because we exist, because we provide treatment. I think that generating significant change in the real world we operate still is one of our big problems. First, almost everywhere, a big elephant continues to exist in the room. Psychiatric institutions tend to be more like human warehouses than places of care. And treatment is not adequate. People are often neglected. They also lack respect for their dignity, often are exposed to systematic human rights violations. Second, still there is you probably don't see my face at this moment, but anyway, it doesn't matter. This means that people still are in difficult institutions. Second, little investment is done in creating community mental health teams or centers, relying on beds in general hospitals. Third, the primary health care role is not sufficiently valued, while primary health care must be the most important support for mental health specialists and for mental health care. So we have three elements: the persistence of psychiatric institutions, the little investment in creating new mental health teams and in creating new beds, not in psychiatric hospital, but rather in general hospital. And number three, the primary health care role not sufficiently valued and implemented. The fourth element that in a way prevents a change in our world is that the person with long-term disability still are in institutions. And then number 5, the lack of investment in prevention, suicide prevention, alcohol prevention, child and adolescent mental problems and development problems prevention, and then minimizing the effects of social determinants. And finally, the last but not least, the fact that human rights literacy and rights promotion is dramatically insufficient. I think that these 6 barriers cannot be all put on the shoulder and responsibility of the minister, the politician, the donor. These barriers in part depend on resources, in part depends on investment, but also in part depend on the way we operate, the way we work, the way we conceive mental health, the way we conceive mental treatment. Ladies and gentlemen, thank you very much from the very cold city of Geneva. I hope that in the next 20 minutes, or rather like that session, you may ask some questions and you may discuss with me whatever you think is an urgent issue or topic that deserves to be discussed. I hope that my face will reappear now on the screen, but I am afraid that this is a little bit a problem. But let me see.
Professor Saraceno, thank you so much for that very informative and riveting presentation.
Yeah,
I must say that it really struck me that you spoke about the epidemiological, the public health, and the moral arguments for elevating the status of mental health in the total healthcare response. What I found very interesting also, Professor Saraceno, is when you spoke about refugees and displaced persons, and how that might be akin to the pandemic and the catastrophic mental health implications that we're currently facing worldwide. And I wanted to ask what your thoughts were for how we can better support families and communities that, as a result of the current isolation and displacement that the pandemic is causing, how do we support their mental health from a public policy standpoint?
That's a very important question. And you know that nowadays, over Europe, your question is at the center of the discussion, because we, the mental health professional, we operate close to the people. We have to touch the people. We have to talk to the people. We have to listen to people. We can't operate like we were using a machine or something which maybe is could be a sophisticated technology, but our technology is essentially a human technology. And our human technology is profoundly affected by the pandemic. However, I don't think that all is negative. There is a lesson that we have learned, we, the mental health people, that if we were able, prior to the pandemic, before the pandemic, to have created a much more solid community network of people, of intervention, of small institutions, small team, probably these would help us better than relying simply on large institutions, which are crowded, and obviously they may become a terrible source of infection and reinfection of the patients and of the staff. So in a way, the lesson learned from the pandemic is also that the community model is even more efficient during an epidemic like the terrible epidemic or a pandemic that we are all experiencing these days.
Yes.
Thank you so much for that, because I think so often we are lost in the humanity of humans, that we do thrive on those physical and emotional connections, and how we run the risk of completely disconnecting from that as a result of the pandemic. Professor Saraceno, you also spoke about the budgetary allocations for mental health and wellness, 2%, even though the disease burden was approximately 14%. So that is a deficit of approximately 12%. And you, more than anyone in this forum, would have an appreciation of the evolution of mental health awareness and mental health practices and interventions, moving from the spiritual model to now the medical model to, a more comprehensive model. How do you propose that we as a community, as a people, advocate for mental health more than we actually are? I feel you had some images up that I thought beautifully illustrated the plight of persons living with mental illness, often forgotten and relegated to a back room, stigmatized still. We don't like to talk about it. It's not very glamorous, and we often don't see the long-term benefits immediately. But how do we as a people, when I was reading your introduction, you were a member of that group that really advocated for deinstitutionalization. So how do we as simple people, lay people, those that are non-clinicians, how do we advocate for a society that sees or citizens who struggle with mental illness and supports them in different ways?
Well, I think that just this common people, the member of the communities alone, they will be never able to change the picture. I see that there are 3 entry points, and the 3 entry points should be operated at the same time. The first entry point is to convince, to advocate to policymakers, to politicians. And to do so, you should use only cost-effectiveness evidence. The minister will be convinced, not by any moral or emotional discourse. The minister needs to know that you are able to change the outcome of your patients, that the model you are proposing, moving from hospital to community, is better, that you have enough science, evidence, studies, epidemiology showing all that, including economic data. The first entry point is more technical and cannot be done by the common people from the community. Should be done by professional to professionals, namely the public health doers, thinkers, planners, and it should be based on evidence. The second entry point that nobody talk about is media. I think that media can be your best ally or your worst enemy. You may have a media, a country, where if a mentally ill person kills someone in the street, the day after, newspapers are full of scandal, shouting and saying that a mad person has killed someone. So mad people are all dangerous, that people should be locked, and so on, so on. On the contrary, you may have a country where media have been educated, have been trained well enough to represent, to have a representation for the public of mental illness, of mental problems could be created by people with mental problems in a decent way, not looking for scandal, not looking for wrong emotional reactions. So it's very important that you work, educate, inform media. And the third entry point should be done by people in the community, with people in the community, showing that, and this is done, showing real experience, real successful experience. You have in Jamaica real successful experience. Experiences of people with mental problems living in the community, living in their family, living in protected apartment, that you have a system. I remember that we have quite an interesting experience of a network of small protected facilities. If you show the neighborhood, if you show the community that this is possible, that this is nice, that this is acceptable, this is the way to decrease stigma and discrimination. Not talking about stigma, not talking about discrimination, but showing that stigma and discrimination can actually be overcome by real experience of social inclusion. And you have, I insist in that, I have seen them in Jamaica, a number of interesting experiences. So
Thank you.
Entry points.
Thank you so very much for that, Professor Saraceno. I see two questions in our chat. One question is, how do you see the integration of mental health in primary and secondary care, allowing for greater investment in mental health in a seamless way?
Well, the question is not completely clear to me. While I understand what the meaning of integrating mental health in primary care, I am not clear about what does it mean integrating mental health in secondary care. Community mental health services are per se secondary care level organizations or teams or operational bodies. So let's talk and let's focus on integrating mental health in primary care. This is a long debate. It started in 1968 in Alma-Ata, when there was a bombastic and rhetoric and fantastic declaration that primary care is the solution of everything. I think that we should also do some kind of self-criticism about two extreme positions. Those who are very pessimistic, and these are very often the psychiatric specialists, saying, no way, primary care can do nothing for our patients. They are incapable, they are incompetent, they can't do it, we have to do it. So it's a specialist domain, no primary care support. This is an extreme position, which in my view, in WHO view, is wrong. But on the other side, there is also an excess of optimistic position, conferring, attributing to primary care omnipotent powers of resolving problems. Our colleagues in primary care are already overburdened. Our colleagues in primary care need supervision more than training. So stop training doctors in primary care in mental health. They are adult, they are colleagues. They don't need training. What they need is coaching, is supervision for a specific case, is a possibility to call a specialist and say, hey, colleague, I have a patient here. I'm panicking. I'm panicking because he's aggressive in family. I'm panicking because he's willing to commit suicide. Help me, support me. I think that this kind of intervention, very often a very simple intervention, even on the phone, reassuring your colleague, is more important than zillion of hours of training. So integrating mental health in primary care is fundamental, but let's not be too optimistic or too delusional, thinking that they will do everything. They will not. But let's not be also too arrogant, thinking that only us, the specialists, are able to offer, to provide support. Primary health care can be a key element in doing two things: filtering the demand to the secondary level for common mental disorders, anxiety, mild depression, sleep disorders, and so on. Second, doing an effective, efficient, intelligent, non-bureaucratic referral and back referral of the patients. Referral and back referral is not filling a paper, is not a bureaucratic act, is a clinical interaction between a doctor and another doctor. That is very important. Your question is, or the question of the public, is very complex and deserve hours of discussion, but we have not the time.
Thank you so much, Professor Saraceno. I have a private conversation question. Given that you stated that half of all mental disorders are evident by age 14 or before age 14, what are some of the practical approaches to investment in child and adolescent mental health services that we can promote having this knowledge?
First of all, let me say that I am scandalized by the fact that child and mental disorders, in spite of the obvious age pyramid of majority of countries of the world, if you look at the pyramid of age, you see that majority of the population often is represented by children, adolescents, or people under 18. In spite of that, still all investment, all resources go to adult mental health. Imagine that. When I became the director of mental health in WHO, there was a department of 20 people in Geneva. No one staff was devoted to child and adolescent mental health. What I did was just to create 2 staff devoted to child and adolescent mental disorder, which is ridiculous. And my successor, Dr. Saraceno, moved from 2 to 3. Very good. We did our effort. I don't blame myself. I don't blame Dr. Saraceno, but I blame all of us. Still, child and adolescent mental health is the Cinderella of mental health care in terms of money, in terms of resources, and in terms of skills, because I think that the collaboration between pediatricians and child psychiatrists is essential. Most of the child mental health should be done in pediatric environment more than in psychiatric environment, or the collaboration, the links between pediatricians and specialists in psychiatry is relevant. And again, the school teachers are key elements in mental health of children and adolescents. So this kind of collaboration is essential for a country where young people represent more than 50% of the general population. So we are all guilty for having ignored the importance of child and mental health care.
Thank you so very much, Professor Saraceno. Thank you for joining us this morning. Thank you for the rousing conversation. Thank you for the wealth of experience that you shared. It was truly beneficial. I know I thoroughly enjoyed, and I'm sure that our other viewers enjoyed. And we look forward to when the pandemic is over and you can come visit us again in the physical space.
With pleasure. I will be honored to work with my colleagues in Jamaica. Thank you very
Thank you
much,
so very
all
much.
of you,
Thank you
for
so
your
much.
patience and your friendship.
And we send you some sunshine, and
Great.
some
We
some
need it.
beach salty
We
air.
need it. We are under the rain. Okay, thank you. Bye. Take
Thank you
care.
so much,
Bye-bye.
Professor Saraceno. Continue to stay safe and healthy during this difficult time. And we look forward to continued opportunities to benefit from your wealth of experience and your passion and zest for mental health and wellness. Ladies and gentlemen, I want to thank you for sticking around with us. We ask you that you will stay with us for a little bit longer because we must send our appreciation and gratitude to the individuals who have made this week as a rousing success and a possibility. I want to invite to the podium Ms. Jody Marie Hastings, clinical psychologist in the Ministry of Health, Western Regional Health Authority, Mental Health Unit. Ms. Hastings?
Thank you, Miss Rose. Good afternoon, ladies and gentlemen. Please permit me to extend sincere gratitude to the multitude of persons and organizations that have facilitated the amazing success of this year's mental health conference. To date, we have had approximately 4,000 views on our virtual platform across all 6 days. We thank you for your support. We must first thank our illustrious speakers and panelists whose expertise and experience have contributed to the charge of investing in mental health. We thank our partners, the Western Regional Mental Health Authority, the University of the West Indies, Department of Sociology, Psychology, and Social Work, Western Jamaica Campus, the Ministry of Health and Wellness, and the Pan American Health Organization. We want to thank Dr. the Honorable Christopher Tufton for supporting this worthy initiative. Thank you to Dr. Cayetano and Professor Saraceno, our illustrious guests, for their exceptional contributions. Our own prodigies, Dr. Earl Wright, Dr. Diane Campbell-Stennett, Dr. Peter Gay Reynolds, Dr. Kevin Goldburn, Dr. Ganesh Shetty, Professor Wendell Abel, Professor Roger Gibson, Dr. Judith Leiber, Professor Maureen Sams Vaughn, Dr. Abigail Harris, Miss Yuki Atkinson, Miss Colette Curlew, and Mr. Michael Tucker. We also must extend gratitude to our moderators who so aptly connected our virtual audience and our speakers. We wish to extend a special thank you to Dr. Patrick Prendergast, Director of the Western Jamaica Campus, and his team for their world-class support. We must applaud Mr. Andre Hewitt for his exceptional technical support. Well done, Mr. Hewitt. Finally, we want to acknowledge the tireless efforts of Dr. Elizabeth Crossman, consultant psychiatrist of the Western Regional Mental Health Unit, for the ambitious conceptualization and operationalization of the successful event. We want to invite Dr. Crossman to the podium. Dr. Crossman? Dr. Crossman? Social distancing.
I'm afraid, Dr. Osman.
On behalf of the Western Regional Health Authority, the Pan American Health Organization, the University of the West Indies, MONA, and the Ministry of Health, we want to thank you for this wonderful event. We look forward to next year. Investing in mental health, the time for action is now.
Thank you.
Thank you, everyone, and enjoy the rest of your day.
We want to thank everyone again for sticking around with us. It has been a wonderful week of presentations. We look forward to next year. We promise it will be even grander and better. Please continue to stay safe. We look forward to serving our communities. Have a wonderful evening, ladies and gentlemen. Thank you.